structure, in terms of you'll see on page 7. Okay? So the thing that I had out here up against the bone slides in histology was this model. And as you can see over there on that counter, I got 2 of them. Yes? What's that? Oh, absolutely. I would strongly recommend it. Yeah, you don't think you're going to get a good recording from back there? So let me advance over to the long bone structures, and you'll see why in a second why I do the long bone structures first. If anybody wants to record. Okay, a long bone, and we can see several long bones here. Our long bones are basically in the appendicular skeleton. But first of all, that's what we're going to cover for the rest of the time after the first few sections here. Whenever you're studying skeleton, it's good to have an articulated skeleton nearby. Right now, it doesn't look like we're going to have open labs because of COVID, but if you're studying it on devices at home, make sure you have a figure of an articulated skeleton nearby. One on that side, one on this side. Everybody got it? Next week, I'm going to cover the axial skeleton, and imagine the axis being like an axle rod in a truck, and the wheels turn around it. Skull, vertebral column, ribs, and sternum. That's the axial skeleton. The wheels that turn around it are the pectoral girdle and the upper extremity, the pelvic girdle, and the lower extremity. That's what we're studying today. Everybody got it? But you can see that the majority of the long bones, in fact all of the long bones, are in the appendicular skeleton. And a long bone, so we're in the long bone structures, have 2 knobby ends. Each knobby end is called epiphysis. Look at the spelling there on page 7. It's epiphyses. Everybody see that? That is not a typo. Epiphysis is singular. Epiphyses, you put an E between the S's. That's plural in Latin spelling. And each long bone has 2 of them, so it's epiphyses. Now, today, in today's lab, it would be good to remember the directional terms. Lateral, medial, superior, inferior, anterior, posterior, and in the appendices, distal, proximal. There's always going to be a distal epiphysis and a proximal epiphysis, epiphyses. In the center is a hollow portion that looks like a bony pipe called the diaphysis. That's spelled on page 7 with an I between the S's because you only have 1 in a long bone. In the epiphyses, sometimes you can see this bony landmark, and it's basically a thicker bone line that is perpendicular to the long axis of the long bone going across the epiphyses. So we call that the epiphyseal line. In lecture, after lecture exam 1, I'm going to explain to you why adult long bones have an epiphyseal line. Okay? All right. There are 2 kinds of bone. On the outside, there is compact bone. And since it's on the outer, it's sometimes referred to as cortical bone, because in anatomy, cortex means outer, medulla means inner. And since compact bone is always on the outside, it's sometimes referred to, you might hear it on clinic floor someday, as cortical bone. Now in the diaphysis, in the middle of the bone where it's hollow, that hollow cavity in the middle has a name, and that's called the medullary cavity. It's right in the middle, and it has to do with medulla. Medullary cavity. Everybody see why they call it that now? Here, this is taken out of an actual bone. In fact, all these bones, I'm not sure about that set, but all the other bones were actually in a living person at one time. They donated their bodies to science. We harvested their bones, put them in a box. Can you see the medullary cavity in cross-section? Do you see how it looks like a pipe? Now, what did I say about adipose today in lecture? It's the great space filler of the body. And in our body, this medullary cavity is stuffed with adipose, called yellow marrow. That's why if you give a dog a bone, it actually wants to crack it to get to the fat in the middle of the medullary cavity, because dogs are like us, love the taste of fat. Yes?
Would you consider that the conduit that we talked about in lecture, like the bones?
No, in this particular case, it's actually not serving any purpose except one, and that is to lighten the weight of the bone without sacrificing strength. This bone is just as strong with a medullary cavity than it would be if it was solid bone. So why not make it lighter, right?
Thank you.
All right, now inside of compact bone is spongy bone, also referred to as cancellous bone. Also, since it's inner, also referred to as medullary bone. What is characteristic of spongy bone, we will see here in a second, are these little struts called trabeculae. And the trabeculae, the little struts, is what makes it look like a sponge. That's why they call it spongy bone. Okay. And here, these two red arrows are on nutrient canals. And we tend to have nutrient canals in the epiphyses of adult bones. When you're growing up as a fetus, there's actually one to the diaphysis, but it eventually closes off. Here's what you want to write next to nutrient canal. It is big enough to see with the naked eye. These are large blood vessels going in and out of bone. And it's so large I can stick the stick in a nutrient canal. You see how big that is? See with the naked eye, you can see it across the room, huh? Can you see the hole right there? You can actually see a nutrient canal with your naked eye, and if it's big enough, you can see it across the room. You see it? You see with the naked eye, it's a nutrient canal. See it? All right, that's long bone structures. Now let's go to microscopic structure, because I want you to understand this model. This model, microscopic model, is taken from a diaphysis of a long bone. Now, one of the things that you'll notice in this picture, if we're talking about percentages, look how the diaphysis is almost all compact bone. It just has a few little struts or trabeculae. Can you see that? It's almost all solid compact bone. Can you see that? Maybe write this next to diaphysis. It's 99% compact bone, 1% spongy bone. But as you get to an epiphysis, look at, here's the diaphysis way over here on the right, where you have the 99% compact bone. Notice how the percentages flip-flop. By the time you get to the epiphyses, you've got an eggshell of compact bone, and the rest of it is trabeculae. So next to epiphysis, right, 1% compact bone, 99% spongy bone. But the diaphysis is 99% compact bone, 1% spongy bone. Everybody see that? Well, this is how you can tell this model was taken from a diaphysis. Look carefully. It is one slice of the pie. Does that look like a pie slice? It's the pie slice I'm covering with my finger. And it's oriented right now exactly as it is in my left hand. Let me walk this across. One slice of the pie, and that slice I'm covering with my finger in this orientation. Everybody see it? Does this not make sense? Yes?
For the epiphysis, you said it's 1% compact bone, 99% spongy bone, and then the opposite for diaphysis. Okay.
Everybody see that? Now do you understand this model? It is one slice of the diaphysis. What does that mean? At the very top, underneath my chin, is periosteum, outside the bone. What it's resting on with my right hand is the medullary cavity. Are you thinking this thing through, or are you being passive? Where my right hand is, right here, my right hand is in the medullary cavity, resting on the 1% of trabeculae, the 1% of spongy bone, where the vast majority of this, do you see the cut tree trunks? The cut tree trunks are osteons, and you only find osteons in compact bone. Everybody see the cut tree trunks? So if trabeculae are characteristics of spongy bone, osteons are characteristic of compact bone. And that's why this is the outside of the pie slice over here, periosteum. And that's a complete layer. Over here, lining the medullary cavity is endosteum. And it's an incomplete layer. In osteon, a couple of these have been telescoped up. Okay? But they don't have to be. It's a cut tree trunk, even if it's not telescoped up. Yes?
So you say you only find the osteon in
Compact bone. There's no osteons in spongy bone. You only find trabeculae in spongy bone. You don't find it in compact bone. Well, if an osteon looks like a cut tree trunk, an individual tree ring is a lamella. The E at the end in Latin spelling is plural. Okay? So this is singular, lamella. This is plural, lamellae. Everybody got it? Let me ask you a question. Lab exam 1 will be the first time we're going to be rotating around the room with models with pins in it. Models are bones. How many lamellae can I pin with one pin? 1. Should your spelling have an E on it? And then why don't you cross it off page 7? Your spelling is going to be lamella because I can only pin one ring with one pin. Okay. Now as we're looking at the flat osteons here, you can see that one of the rings is labeled there lamella. In the center of the osteon is a hole we call the central canal. I would put a single line through haversion. Central canal can be big C, little c. And it describes where it is in the osteon, right in the center. Notice that the lacunae here in this picture are located in the cracks between lamellae. They are not in the middle of the lamellae, they're in the cracks between them. Can you see that? Where it says lacuna? How many lacunae can I pin with one pin? One. Better cross off the E. Lacuna. Now, you just got to read the question on the little card in Lab Exam 1. So for this lab quiz, you had to listen to the question that came out of my mouth. On the lab exam, you got to read the question written on the card. Everybody got it? If I pin this, or this, or this, or this, or this, and the question on the card said, what is the name of the space the two-way pin is located? What is the name of the space? Lacuna. Same pin, different question. What is the name of the cell that lives in this space where the 2A pin is located? What is the name of the cell that lives in the lacuna in bone? Osteocytes. I'm not going to use this little cartoon painted spider. I'm just going to pin a lacuna, and you got to read the question. The name of the space is lacuna. The name of the cell that lives there is osteocyte. Now those osteocytes that live way out here in the outer rings, there's an osteocyte that lives in here, now they're here. How are they getting oxygen and getting rid of waste when the blood supply is in the central canal? By these radiating cracks called canaliculi. That's why the oxygen is diffusing all the way out through, boom, feeding the cell. CO2 is diffusing back in here to get into a vein. Everybody see that? So canaliculi penetrate lamellae. Canaliculi penetrate the tree rings, lamellae. Okay. The outer periosteum is tacked down onto the bone by these white lines called perforating fibers. They are perforating these circumferential lamellae. We'll talk about that in lecture. But those white lines are perforating fibers. You can call them Sharpies if you want. I wouldn't. Put a line through Sharpies. Perforating is describing what those white lines are doing. It could be big P, little p. Perforating fibers. Now, this model, or the slice of the pie, would be oriented like this, which means these central canals are going parallel the long axis of the long bone, like this. Which means all the red lines that are vertical you see here have to be a central canal in the middle of an osteon. Everybody got it?
Yeah.
Any artery here that is not horizontal. Not vertical. All the vertical ones are central canals. You can see here. But anything that is not vertical is a perforating canal. Old name is Volkmann's. I would put a line through Volkmann's. It's a perforating canal. Okay? Any questions on that? Vertical is a central canal. Anything that is not vertical, perforating canal. You can see it from across the room. And then lastly, this is now from the viewpoint of the medullary cavity. You can see endosteum is not a complete layer. Maybe next to this slide, you should write, from this view, if it's white, it's endosteum. If it's yellow, it's trabeculae. And can you see these labeled lines here? Endosteum, it's going to white. Trabeculae, it's going to yellow. Yes?
This is from the side of the bone?
What's that?
This is from the side of the bone?
This is on the inside, up against the medullary cavity, endosteum. So remember this slice of the pie thing, right? This is outside, where this hand is the medullary cavity. All right, did we cover the first two sections there? Yeah. All right, let's go ahead and take a break. That clock is wrong. You know, I mean, how difficult is it for a college to fix all the clocks? Like for anatomy, we're 2 for 2. The clocks are off. Lecture hall, it's off. Lab room, it's off. But at 2:05, I'm starting with or without you. So definitely be back by 2:05.
Professor Lin, so for future reference, if we ever have to drink water, do we have to step outside because of the mask stuff? Yeah.
And that's why it'd be good if they actually institute a true vaccine mandate by October 1st, because then by October 18th, then I would say, no, you can go ahead and drink in here. Just put your mask back on afterward.
I was going to ask about, I tried to send the PowerPoints to the graphics center to be printed, and they told me that they weren't able to open them. Do you know what I should, I just sent them I downloaded it on my computer and sent them the file.
Yeah, I don't know why.
Okay. Do you know how I would, they said maybe download it as a PDF. Do you know how I would do that?
You can actually print your PowerPoint handouts instead of printing it to a printer. Say print to PDF and turn it into, and that way you can decide how many slides you want on a sheet.
Okay.
And then you can send the PDF that way. Probably that would be better.
Okay. So I would just print it as if I was printing on my computer.
Just say print to a PDF, and then it actually saves it in your folder. Give it the same name for the file as a PDF, and you can attach that to the print shop.
I'll try that. Thank
Okay.
you.
I'm in no rush, but will the grades for the quiz be in Canvas whenever you finish?
Uh-huh.
Yeah,
When would you like them?
As soon as you can get them done.
Would today be too soon?
No,
Okay,
I think I did good, so
okay.
I'm not worried.
All right, good.
Will you let us know our grades by the end of the day?
Well, since it looks like I'm going to have to speak at the board meeting about this fiasco that they're trying to pull, I'll probably just stay here until I get them all graded and posted. Did you guys hear what they want to do?
No.
They want to allow unvaccinated people to still attend classes live, and they're trying to give as many exemptions as possible, including, at this point, I don't know if it's going to be limited to medical contraindications, religious reasons, and strong personal beliefs that are not religious. In other words, all a student has to do is say, I really don't like vaccines, and they can come to class live. That reduces a vaccine mandate to a vaccine suggestion. It's just stupid as. And I can't believe these people are on the board of trustees and the upper administrations, and they're actually thinking about doing that. And I have to remind them of the common sense that we used to have as Americans. Like the common sense that 70 years ago, there were much fewer people with certificates and degrees. But we have so much less common sense now. Because they're actually thinking that this is a viable alternative. Well, the common sense 70 years ago eradicated polio and measles and mumps, rubella, and they're just gone because people had common sense and they had humility to know what they didn't know. And they wouldn't go on YouTube to instantly act like an expert that they're not. And so we have had enough vaccines since they were released in December to achieve herd immunity in August. Today's the last day of August, which means we should have had herd immunity already, which means everything could reopen fully and safely. Every business, every school, every concert venue, every sports stadium, all of it could be open safely. Now, of course, we'll still have the virus. There'd be a case here, and a case there, and a case there, and a case there. But they're surrounded by vaccinated people, which means it has nowhere to go. That means that person will be sick, but as soon as they're over it, boom, that little island is gone. This little island is gone. This little island is gone. And so because there would still be islands, if we had herd immunity in August, this semester we would still need to have these masks, even with herd immunity. But after this semester, if we had herd immunity in August, there's a really good chance we really wouldn't even need these in spring. No masks, everything wide open, basically the way some people have wanted it to be. Except they've wanted it to be without paying the dues. And the dues is having common sense to get vaccinated for those who can. And when those who can get vaccinated do get vaccinated, it protects those who medically cannot be vaccinated. And we would have had that already. Just think about that. We'd already be getting past this. One more semester of wearing masks, but you can go to any bar, any concert, any sporting event, and not sweat it. Right now, everything is a sweat. And the way variant development has gone, the window is closing on us to get herd immunity. if these people are successful in preventing us from getting herd immunity against all these variants, this reality, mass and people getting sick, will be with us for years. As it was with the Spanish flu. 1917 to 1918, they had about 2.5% lethality rate. Anybody who got it, you had a 2.5% chance of dying. COVID is already surpassing that. And we have 3 vaccines. The world couldn't get a vaccine in time for the Spanish flu. Without a vaccine, 2.5% people died. We got it. We're there now with vaccines because we don't have common sense. And we got board and upper administration wanting to give people this option. I just don't like the vaccine. Well, then you go ahead and come live. And I rather would just relax after this long day and grading your quizzes and posting them. I'd rather relax after that. I got to remind the board and the upper administration what common sense looks like. And I got better things to do. All right, let's go. Let's get started. And jump to articulations and skeletal terms before we get to the appendicular skeletons. This won't take long. Turn to page 13. Page 13 is the words. Page 14 is the picture. Everybody see that? All right. Now remember, I don't have... this is going to be the extra credit for Lab Exam 1, 8 out of the 10. You guys remember me showing you this? Notice there's an A question and a B question. Everybody see the 2 columns? A's on one side, B's on the other. For these 4 stations, 8 points, the A question is going to be, what is the name of the major functional classification? If you look on page 13, those are the capitalized words. You don't have to capitalize it, but those are the capitalized words. Functional classification means these are being classified by how much they move, how much they function. If they don't move at all, synarthroses. E between the S means plural, I between the S is singular. If it moves a little bit, it's amphiarthroses. If it moves a lot, it's diarthroses. Everybody see how those are functional classifications? And there's only 3 of them. What you might want to write next to that on page 13 is the capitalized words would be the answer in the A column. The small case letter words would be the minor subtypes. That would be the B question. So capitalized words goes in the A column. Small case letter words go in the B column. And I'm going to basically use blank pictures like what's on page 14. It'll just have a line or 2 instead of all those lines and words, just a line or 2. And it will ask a question on what's the major functional classification, and B, what is the subtype? Yes?
And that's only referring to the extra credit, not...
Yes. And that's why I'm showing you the back of the sheet. Not all 10, but 8 out of the 10. Okay? So you have synarthroses sutures. You also have the syndesmosis. And look on page 14, bottom left. You've got to be talking about the syndesmosis in the leg. Syndesmosis is a bunch of fibers between the tibia and fibula. Even though you have one in the forearm, this one is an amphiarthrosis, and that's why you can do this. Can't do that with your foot. So the one in your leg is a synarthrosis. It doesn't move, but this one is an amphiarthrosis. It's not on page 14, but I will cover this in lecture, and students will commonly go, well, I thought you said that the syndesmosis is a synarthrosis in lab. Well, the one in the leg is. Everybody got it? All right, and then we have amphiarthroses that move a little bit. Synchondrosis basically means the joint or articulation is going from bone to hyaline cartilage to bone, synchondrosis. Symphysis means it's going from bone to fibrocartilage to bone. You see that on page 13. Well, synchondrosis, that moves a little bit, is like between your bony ribs and your sternum. If you look at these skeletons, they had to put a little filler that's not bone. This is supposed to be hyaline cartilage. Bone, hyaline cartilage to bone is a synchondrosis. And this one moves a little bit, and that's why you can go like this. Right? Ribs are expanding, coming back. They're moving a little bit. Symphysis. The ones that move a little bit, we have the fibrocartilage of the intervertebral disc. If you're able to do this, that's an amphiarthrosis. It's moving a little bit. The pubic symphysis is, you got to argue if that's an amphiarthrosis. The pubic symphysis is, I guess it's amphiarthrosis for women, because that thing moves a little bit at the first childbirth. Except for the first childbirth, that thing never moves. Which is why men's pubic symphysis actually never moves. Diarthroses are all over there on the right column of the figure, page 14. Ball and socket is real obvious, shoulder and hip. Hinge is pretty obvious, knee and elbow. But the knee can only hinge. If you look at the elbow, it can hinge and it can pivot. That's why it's both. All right, and the rest of them, saddle, condyloid, gliding, planar, those are in the feet and the hands. There's some other ones too, but just learn them and then just follow it on the figure on page 14. Just make sure you remember that column A is the major functional classification, the capitalized word. Column B is the minor subtype, small case words. You mix them up, those are wrong. All right, turn to page 15 for skeletal terms. And these are for various bony landmarks. And let's just go through them. Well, instead, on just to the left of those terms, let's put a few symbols. Either a plus, because it sticks out. Howdy. Minus is an innie. 0 is flat. And then we will have a plus minus. It sticks out, but has a groove in it. All right. First one, condyle, is a plus. It sticks out, it's smooth and rounded. Crest is a plus. It's a prominent ridge. Facet is a 0. It's flat. Fissure is a minus. It's a long crack or cleft. Foramen is a minus. It's a hole that goes all the way through. Fossa is a minus. It is a shallow, cup-like depression. Head is a plus. Line is a plus. It's like a mini crest. Meatus is a minus. It's a hole, but it doesn't go all the way through. That's what it means by a canal with only one entrance. Process is a plus. That's a generic term. If we can't fit it into any of the other terms, we'll just call it process. And it sticks out, it's a plus. Ramus is an angled plus, so that's also a plus. Spine comes to a point, that's a plus. Trochanter, I would put 2 pluses on it. They're huge. And there's only 2, and they're on this huge femur. These 2 big bumps here. Trochanters, 2 pluses. Trochlea is the plus minus. This is the plus minus. It's actually one of the condyles of the humerus, so it sticks out, but it's got a groove in it, and the groove is guiding this hinge. Okay? Tubercle is a plus. Tuberosity is a plus.
What was line again?
What's that?
Line?
Line is a plus. It's a mini crest.
Can you repeat condyle?
Condyle is a plus.
Thank you.
Now turn to page 7. Look, go down to where it says appendicular skeleton, and just go down the list of structures that you have to know. And do you see some of those terms? Tubercle, fossa, process, fossa, 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 spine, tubercle, tubercle, head, tuberosity, fossa, fossa. And you see why I went through the skeletal terms first. Any questions? All right, last portion of the lab today, I am going to give you a choice about because it's already 2:15. If you notice on where it's embolded, it says appendicular skeletons, 126 bones, all paired, right? You have to know right from left. Actually, if you go to turn to page 8, the carpals, metacarpals, and phalanges on the top of page 8, I'm only going to use a right hand anterior view. So obviously you don't have to do right or left for the hand or carpal bones.
Carpals, metacarpals, and phalanges. You're only doing a right hand view.
Right hand anterior view. I haven't done it in a long time. I know this is a right os coxa, but I think especially coming back live, this is hard enough. So you can go ahead and say no right or left for os coxae. You don't have to know right or left for patella or fibula. On the top of page 9, where we'll finish, tarsal bones, metatarsals, and phalanges will all be a right foot superior view. Are you starting to catch why you need to remember the lateral, medial, superior, inferior? You need to know that for this. So if the top of page 9 is only going to be right side, top of page 8 is only going to be right side. I'm not going to ask you os coxa. I'm not going to ask you patella or fibula, right or left. That means the only bones you need to know right or left for are the 1, 2, 3, 4, 5 on page 7, femur and tibia on page 8. That's it. Everything else you don't have to worry about knowing right from left. Does any of you need that repeated? Which part?
It's the femur and the what on page 8?
Femur and tibia on page 8. Those are the only bones you have to tell right or left from. Anybody else need it repeated?
You said the right superior view for the tarsals?
Right superior view for the tarsals, metatarsals, phalanges of the foot.
Thank you.
Any other questions, clarifications? Okay? Well, this is what you want to write regarding where it says no right from left for those 7 bones. You need to identify structures on 2 planes. You must identify structures on 2 planes to determine right from left. For example, and I don't know if you want to do this, but you can also start numbering, starting from clavicle, sternal end is number 1, acromial end is number 2, conoid tubercle is number 3, just that column, just number it all the way down to 27. You can also number 28 up at scaphoid, go all the way down. Staying in the right column. When you get to the os coxa, obturator foramen and acetabulum should actually be on the right column with pubic symphysis. But number that column all the way down to 66 on the bottom of page 8. And that's all you need to do for today. That will make this a lot better on your notes. What I would do if I were you for the rest of the semester with anatomy lab is I would print up 2 lab PowerPoints. 2. One to take notes in lab and to study from. And after you drilled and drilled and drilled, the second PowerPoint you could use as your final self-test before lab exam 1. Can you fill out this PowerPoint, all the lines and blanks, without looking at your notes? If you can, you're scoring in the 50s on lab exam 1. That second PowerPoint is your self-test. Not only is it a self-test of knowledge, guess what else it is? It's a spelling check. You could see if you spell them right. That's how you kick ass in anatomy, okay? But right now, to help speed it up, you could just write numbers. For example, if sternal end is number 1, here's a clavicle. It is this thicker end. This is number 1. The acromial end is number 2. The sternal end is medial, and this is why you want to have this guy out. Because the sternum is here, the sternal end is medial, articulating with the sternum. The acromial end is way out lateral. And it is articulating with number 6. What's number 6? Acromion. There are a few places, not everywhere unfortunately, but there are a few places where the names actually make some sense. The acromial end articulates with the acromion. That name makes sense. And you can definitely see it when you have an articulated skeleton around you, which is what I would always have so that you don't lose sight of the forest for the trees. Any questions? Yes?
You said to number page 8.
You'd start with number 28 on scaphoid. Hamate is 35. Metacarpal's 36. Pollex 37. Fingers 38. Anterior inferior iliac spine is 39. Just go all the way down that column. Unfortunately, obturator foramen and acetabulum need to be scooched over. They need to be numbered as well. They would be 49 and 50. Fovea capitis 51. You follow that all the way down. You end with 66. Okay? It'll just make it faster writing down the numbers than spelling it out now. Does that make sense? And here's your choice. If you want, I can go through all the things listed that you are responsible for the appendicular skeleton, lab exam 1. Or, for those bones that you have to tell right or left, I can just show you the 2 structures or 1 structure, doesn't matter, but 2 different planes so that you can determine right from left. and you can go with the textbook or the internet to fill out the rest of them, which will make it really fast. And I know you're tired from the lab quiz, and I still have to grade the lab quiz. So which one would you like? Would you like me to go through all of them, or would you like me just to go through the two things on two different planes so that, and you guys do the rest yourself? Who votes for me going through all of them? Who wants to just have me go through two things per bone and you do it on your own? Sweet. We're going to just do it that way. Awesome. All right. Well, again, I already told you sternal end is on the left side. Acromial end's on the right side. And this is that sternal end. It's much thicker. The acromial end is flat like an upside down spoon. Does that kind of look that way? Like a spoon? But here is the only thing that you need to tell right or left clavicle. And this is the conoid tubercle, because this one thing is on two planes. Look at it carefully. This is a lateral view of a right clavicle. Okay? If this is a right clavicle lateral view, that means the conoid tubercle is on the posterior side of the bone. And notice it is pointing down, inferior. Okay? Let me just run this by you so that you understand what I mean by two different planes. Sternal end is medial, acromial end is lateral. That is one plane. Medial lateral is one plane. Superior inferior, one plane. Anterior posterior, one plane. If this is medial and lateral, that's not going to help you determine right from left. By the way, 5 stations of bones are going to have a bone with no pins on it. Okay, I'm giving away points if you want to hear them. The A question is going to be, which bone is it and from which side of the body? That's the A question. On this, the reason why there's no pin is those stations, you can actually pick up the bone and put it on your body. Can't do that if there's pins. Everybody got it? Okay. The B question is going to be, did you listen to me when I said you need to have an articulated skeleton around when you're studying these things? Because it'll ask, like, what is the most lateral landmark? Or what is the most proximal landmark? Or what structure of what bone does this articulate with on the distal end? Because I don't have any pins. I have to ask questions like that after the A question is, what bone is this and from which side of the body? Everybody got it? But look at this. Watch me carefully. The thicker sternal end is medial. The flat spoon-like acromial end is lateral. That's not one plane won't get you there. Why? Because I can hold it like this, and I can hold it like this. And the whole time, sternal end stayed medial, and acromial end stayed lateral. One plane, you cannot tell right from left. Are you looking at me? Because this sounds simple, but this is where students lose a lot of points, because they just take for granted it's simple, and it's not. My job is to make the complicated sound simple, but that's a curse, because I'm actually really good at it, and so students will veg, because, oh man, this sounds so simple. And they don't put adequate effort into it, because they think, oh, it's so simple. So one plane doesn't do it, and that's why you need something like the conoid tubercle, which by itself is two planes. It is on the posterior side of the bone, and it's pointing down. Look at this. This bone is actually in my hand. I took pictures of it because it has the best conoid tubercle out of the whole room full of bones. Can everybody see the conoid tubercle pointing down? Right here. My fingertip is on it. Can you see it? Watch. If I try to put this over here, and it's pointing down, it's on the anterior side of the bone, and that's wrong. Let me put it over here so it's on the posterior side of the bone. Well, now it's pointing up, and that's wrong. The only way this thing works, and hopefully you wrote it down next to conar tubercle, posterior, pointing down. Because now when you hold it on your body, the only side that this works, that it's on the posterior side of the bone and pointing down, is when I put it on the right side. This is a right clavicle. Okay? All right. Now this is going to be really quick. You can figure that out. The thicker side on the right is sternal end, flat side is acromial end. Thick side is the sternal end, flat side is the acromial end. You can also see here that the conar tubercle is actually more lateral. Conar tubercle is really close to the acromial end, and it actually does participate in the shoulder joint. Okay. Now the scapula. This arrow is the glenoid cavity or glenoid fossa. Either gets you the full point. Next to that, you want to write lateral. This arrow right here is on the spine, and the spine is posterior. There's your two planes. The arrow at 12 o'clock is spine of the scapula, it's posterior. You might want to write this. This is the acromion here, off in the upper right, that articulates with the acromial end. You may want to write this next to the acromion. It is the lateral end of the spine. So follow that spine out to the lateral, you hit the acromion. But there's all we have to cover for scapula, because that's all you need. Glenoid cavity lateral, spine posterior. If you look at an articulated skeleton, you can see why the spine has to be posterior. Because if it was anterior, it'd get locked in your ribs, and you wouldn't be able to do jumping jacks. That's why the spine's got to be posterior. Okay, now we're down to the humerus. This up here is the head of the humerus. There are several bones with heads, so you have to say head of the humerus for the full point. If there are multiple named structures on multiple bones and you don't identify the bone, you get a half point. I just gave away some points right there if you had the awareness to write it down. So this up here is the head of the humerus, and it is medial. Obviously, if you look at the ball and socket joints on these articulated guys, if the glenoid cavity is lateral, the head's got to be medial to meet it in that ball and socket joint. This is the lesser tubercle. This over here on the far left is the greater tubercle. But this in the middle is the lesser tubercle, and that is anterior. There are your two planes. Head is medial. Lesser tubercle is anterior. Okay, this does get a little bit complicated, so maybe I should explain this. Turn to page 8, go to the bottom. Page 8, bottom. Last thing under femur is what? First thing under tibia is what? Good, because they are unnamed, they're just called lateral medial condyles. The condyles of the humerus are named. Okay? The round condyle is called the capitulum. And this guy here, the medial condyle, so this is the lateral condyle, but it's called capitulum. This is the medial condyle. That's called the trochlea. And the trochlea, as you can see, sticks out, but it's got a groove in it. Trochlea, the 1 plus minus. The bumps around condyles are called epicondyles. And so since these, even though they're named capitulum and trochlea, these are the humerus's condyles. So these bumps are epicondyles. Okay? If this guy gets inflamed, medial epicondylitis, I think they call it golfer's elbow. If this one gets inflamed, lateral epicondylitis, I think that is tennis elbow. Little medical trivia. Okay, everybody got this? What's that? This one? This is a fossa, and this is also some of the names that actually make sense. On the humerus, this is the coronoid fossa. I guess that's 16. What is the what is 22, or the middle one in the ulna? Coronoid process. So this is actually one of the names that makes sense. If your elbow is all the way bent, the coronoid process of the ulna sits in this cup. Everybody got it? In fact, this bigger cup on the posterior side, that's called the olecranon fossa. And what's the first thing listed under ulna? Number 20. Olecranon. When the elbow is completely straight, the olecranon of the ulna is sitting in this fossa. So these are examples of names that actually do make sense. But they only make sense if you listened to me and had an articulated skeleton around. Everybody got it? Look, you can see the elbow straightened out, olecranon sitting in the olecranon fossa on the posterior side. Okay. And that's, in fact, what you're seeing here. Olecranon fossa, olecranon sitting in it when the elbow's straight. All right, with that little bit, I will let you reconsider your vote. Who here wants me to do 2 things per bone so you can tell right or left? Who wants me to go through the entire list? So I just screwed myself? Is that what you're saying? Okay. I think I got everything in the clavicle though, huh? Okay. Again, sternal end, medial is thicker. Acromial end, lateral is flat like a spoon. Conoid tubercle is closer to the acromial end, but it's the conoid tubercle that's going to help you determine right from left. Posterior, pointing down. We covered some of this. Here's the spine, posterior. You end at the lateral end of the spine, that's the acromion. Since the spine is posterior, so is the acromion. But onto the anterior side is the coracoid process. And that's here, this arrow at 3 o'clock. Coracoid process. That's on the anterior. Now the spine forms, because it sticks out, it forms 2 cups. There's a cup above the spine, and that's this arrow. And that's the supraspinous fossa. And there's a cup below the spine. That's the infraspinous fossa. Okay. Are you curious why we do the bones first and then the muscles? Is anybody curious about that? No? Okay. Well, turn to page 16. Keep your finger here on page 7, but turn to page 16. In 2 weeks, we cover this page. This is Lab Exam 2 material, but go to the top right of page 16 to the rotator cuff. Are you at the rotator cuff, top right, page 16? There's supraspinatus and infraspinatus. They come out of those fossas. In fact, toggle back to page 7. On the last thing under scapula is subscapular fossa. Now go back to rotator cuff. The last of the 4 rotator cuff muscles is subscapularis. Those names will make much more sense on the muscles if we cover the bones first. That's what we're doing. Okay? But this is a posterior view. Spine's on the posterior. On this one here, this is a lateral view. And this is the glenoid cavity because it's pointed to the lateral. But if this is the left scapula, that means this is posterior, this is anterior. That means this is the spine, because it's on the posterior. And when you come right up over here, the closest point to the camera, that's the acromion, the lateral end of the spine. If you notice, the scapula kind of looks like a capital Y, doesn't it? Well, the posterior arm of the Y is the spine and the acromion. The anterior arm of the Y is the coracoid process. Put a little star next to coracoid process. And on to the star right, watch the spelling. This is coracoid process, number 5. What's number 22? Coronoid process. Spelling counts. We also have a coronoid process on the mandible as well. This is the only coracoid process. All right, anterior view. Again, if it's anterior, the one closest to you is the coracoid process. One back in the picture is the acromion. Obviously, on the far lateral side is the glenoid cavity, but this is the subscapular fossa right here. It is anterior. Look at the words on top. Anterior. And that's where the subscapularis arises from. Everybody got that? This is the ball and socket shoulder joint. You can see how the head of the humerus has to go medial. This is actually taken off of this model's left shoulder. So you can kind of see the familiar bracket on the model as well as on this picture. All right, so this is the coracoid process going to the anterior, since this is an anterior superior view. Head of the humerus going to the medial. Up on top is the acromion. Top right is acromion. And if that is the acromion, what's top left? That's articulating with the acromion. The acromial end, that's top left. That's the clavicle, and the acromial end articulating with the acromion. All right, so now let's go here to determine right and left humerus. Head is medial, lesser tubercle is anterior. Point right at the camera. Anterior view, anterior. Greater tubercle is this guy, and that's lateral, but that won't help you with right or left because the head is medial. About a third of the way down the diaphysis of the humerus, you'll see this roughened bump on the lateral side of the diaphysis. That is where the deltoideus inserts. which is pulling on the bone this way when you're doing this. That is the deltoid tuberosity, this arrow. And that also shows you a lot of these pluses. Everybody look at me. A lot of these pluses are there because of muscle pulls. When you pull on a muscle, you activate the bone-forming cells called osteoblasts. They lay down more bone, and before you know it, you got an outie. When you're born, if we just went with newborn bones, this would be a real short lab exam because these bones hardly have anything. It's not until they're up and about in gravity and then starting to stand up and crawl that they start forming these bumps. A lot of those pluses are from muscle pulls, and that deltoid tuberosity is a good illustration of that. All right, this is the distal end. That's the olecranon fossa. Again, posterior view. Much bigger on the posterior side. But when your elbow's straight, the olecranon sits in there. This arrow here is the trochlea. You can see the groove in it. Right here. Trochlea, you can see the groove in it. That's an epicondyle. Since that's how it's written on page 7, you just have to say epicondyle. It's a bump next to the condyle. That's a coronoid fossa. Again, when your elbow's bent, the coronoid process is sitting in it. And then I think we got this already. Capitulum, lateral condyle, trochlea, medial condyle of the humerus. But you have to say capitulum and trochlea. But these bumps next to them are epicondyles. Epicondyles, the bumps next to the condyles. Here's the olecranon sitting in the olecranon fossa with the elbow straight. It's on the posterior side. Here's the coronoid fossa on the anterior side. It's much smaller. But imagine this rotating over. When the elbow's fully bent, that point, coronoid process is sitting in that fossa. This is the capitulum. It's round and it articulates with the head of the radius. Got to say of the radius. So the trochlea articulates with the trochlear notch of the ulna. The capitulum articulates with the head of the radius. All right, so if looking at this picture, can you answer this question? How many bones are there in the arm? Does that sound like a trick question? There's one bone in the arm. The arm brachium goes from shoulder to elbow, and you only have the humerus. From elbow to wrist is your forearm, antebrachium, and there you have two bones. The ulna and the radius. Everybody got it? All right, both radius and ulna have styloid processes. So you have to say styloid process of the radius, styloid process of the ulna. There's the olecranon there. And it is actually the most proximal point of the ulna in anatomical position. Trochlear notch articulates with the trochlea. In fact, this is the giveaway. This is the ulna because the trochlear notch is like a U. Can you see the U? Ulna. Trochlear notch. I would write trochlear notch is anterior. that is the coronoid process that sits up in the coronoid fossa when your elbow's bent. But this is how you're going to tell right or left ulna. The trochlear notch is anterior. I mean, I don't know anybody who has elbows that bend backwards. Trochlear notch is anterior. But this is the radial notch. And the radial notch is lateral. There's your 2 planes. But this is how you got to do right or left ulna in the lavi center. First, you have to know which of the 2 forearm bones are lateral. Next to radius, right, radius goes to the thumb. Radius goes to the thumb. This is going to help you all the way through lab exam 4 when we're doing arteries, and there's an ulnar artery and a radial artery. Radius goes to the thumb. That's worth a lot of points in lab, not just for the bones. So if you're in anatomical position, isn't this anatomical position you got to know for lecture exam? Which of the 2 forearm bones is lateral, radius or ulnar? Radius, because my thumbs are lateral. Can you see my thumbs are lateral? If radius goes to the thumb, radius is lateral. Ulna is medial. So if you have an ulna on the pickup on one of these stations, and there's a good chance because I only got 7 bones I'm going to ask right and left, and there's only 5 stations for doing it. You got to put this over here on the medial side of your forearm with the trochlear notch anterior. Can you see this? But it's got to go to the pinky. Everybody got it? It's either going to be left or right. You following me? All right, let's see. I shouldn't have talked you into this. If you put it over here on the pinky side with the trochlear notch going to the anterior, you got to slide it down your forearm like a rifle. And when you see this in that angle, sliding it down like a rifle, you can actually see the circular cutout where my finger is. Everybody look. Can you see the circular cutout where my finger is? My finger's on the radial notch. I'll come over here in just a second. The reason why it's circular is that's how you can tell this is a radius. Because the head of the radius is like a disc or a circle. And a circle has circumference, diameter, and a radius. Got it? Well, look at here. Look where I'm tapping it. The circular head of the radius is perfectly parallel to the circular cut radial notch. Can you see that? It's a cutout for the radius that is lateral because it's going to the thumb. You follow me? Can you see the cutout? Sliding it down like a rifle. Right where I'm tapping it. Can you see it over there? See how it's a circular cutout with the circular head of the radius? Okay, right where that's happened? That means the radial notch has got to be lateral because that's where the radius is. It's going to the thumb, which is lateral. So if the trochlear notch is anterior and I put it over here, and I see the cutout, circular cutout where my thumb is, this is on the wrong side. Because this radial notch is medial, and there's no bone to the medial. The ulna is the medial bone. So that's why I'm going to put it over here on the right side. Trochlear notch is anterior, and now I can see the radial notch is headed toward my thumb side, where the radius is. Because the radius goes where? To the thumb. This is a right ulna. but you gotta look down the ulna like a rifle to see that circular cutout going to the lateral. If it is to the medial, it's on the wrong side. All right. I'm working way too hard. Okay, there's the head of the radius. It's a disc. Really close to that is the radial tuberosity. Next to radial tuberosity, right anterior. Head of the radius is up on top, but the second arrow below it is the radial tuberosity, and as you can see, it is anterior view. It does have a slight medial inclination. In 2 weeks, we'll talk about why. Okay? But for now, just know it's on the anterior side. It's where the biceps brachii inserts. And if you're doing biceps curls, it's pulling on the anterior, is it not? And then osteoblast makes this tuberosity. Second thing is styloid process is lateral. So there's your two planes. Radial tuberosity anterior, styloid process lateral, you got two planes. The other one is the head of the radius, just like styloid process, lateral. And that is page 7. Let's go ahead and break one more time. Come back at 3:05 and we'll finish. Hopefully it'll go a little bit faster. I can erase this in the middle, can't I?
were trying to figure this one out. Right here, we didn't catch that one.
That one is the olecranon fossa.
Okay, so would this one be the olecranon fossa
Uh-huh.
as well? And then that would articulate with the
Olecranon,
Okay,
uh-huh.
perfect. Thank you.
Yeah.
Excuse me? Which one's this top one that goes right here?
That's the coronoid process.
Okay, thank you. All right. We're on the top of page 8. Let's go faster. We only got 2 bones that we have to determine, right and left. Okay, so here we have the right hand anterior view. If I ask this on the lab exam 1, it'll be right hand anterior view. What you need to know is carpal bones are in the wrist. Carpal bones are in the wrist. Metacarpal bones are in the palm of your hand. And phalanges are out in the digits. You got that? Look at your hand.
Carpal bones in the wrist. Metacarpals in the palm. Phalanges are out in the digits. You have 8 carpal bones. You only have 7 tarsal bones because 2 bones are fused. So there are, out of the 8, there are 4 proximal bones. And to go in order, we got scaphoid, lunate, triangular. Which is easier to spell, triangular or trichotrum? Yeah, triangular. And sitting on top of the triangular, like how I've drawn it over there, is the pisiform. So it actually sits on top of the triangular, not next to it. These, this picture was taken of bones that are being held together by fishing line. So those are the 4 proximal bones, the 4 distal bones. And this is where you got to be kind of careful because you got a bunch of T's. Trapezium, trapezoid. The largest of the carpal bones is capitate. And I didn't draw it to scale, but that's why I sketch it out like that. It's the largest, so I make it really big to remind me. See the C? Biggest. And the last one is the hamate, and the hamate has a hook on it. And that's this one. It is the hook of the hamate and the pisiform sitting on top of the triangular that forms the medial wall of the carpal tunnel, going through the carpal bones. Have you heard the term carpal tunnel? Now, the medial wall is formed by 2 of those bones, pisiform and the hamate. Okay, you got to know that digit number 1 is, Roman numeral 1 is the thumb, and the thumb is called pollex. So this would be Roman numeral 1, metacarpal, 2, 3, 4, and this arrow is on metacarpal Roman numeral 5. Okay. They're in the palm of your hands. And then out here at the distal end are the phalanges. So you can look at your own hand and you can tell there's only 2 on the pollex. And the reason why it's important to call it pollex is because, go to page 16 again. Bottom left of page 16, we have pollicis muscles. That's moving the thumb, pollex. Everybody got it? But there's only 2 phalanges and 3 on the regular fingers. You need to know the names of it because it just gives you the number. Contains 2, contains 3. That intuitively means you got to know the name of it, especially when the names are this straightforward. Proximal phalanx or phalanges. I'll let you say phalanges even though it's plural. Proximal, distal. Phalanges, Roman numeral 1. Proximal, middle, and distal phalanges, Roman numeral 2. Everybody got it? It's either going to be proximal or distal in the thumb, proximal, middle, or distal in the regular fingers. Any questions?
Yeah, I do have a question. For trapezoid and trapezium,
Uh-huh.
which one's which? Which is closer to the thumb?
The farthest lateral is the trapezium.
Okay. Thank you.
So yeah, if you look at this thing here, scaphoid, lunate, triangular, pisiform, trapezium, trapezoid, capitate, hamate. Okay? Some people use a mnemonic for this. A student told me. Some lovers try positions that they can't handle. Whatever works. Okay, we're done with the upper appendage. Any questions? Good? All right, let's go to the lower. Now, the upper girdle, pectoral girdle, is not weight-bearing. And that's part of the reasons why the clavicle is the most frequently fractured bone in your body. You can trip and fall and have all your body weight go on your upper extremities. This is not weight bearing. This is what's connecting the upper extremity to your axial skeleton. And it's just tiny. Snap. Or even just having the seat belt going across here while you're driving. Rear end somebody, tightens up, snap, seat belt just cracked. The pelvic girdle, though, is really weight bearing. This is the sacrum, just right sacrum. We're going to talk about the sacrum next week. It's part of the vertebral column. But you could see all the weight from your trunk and your upper extremities are going onto the sacrum, and it's going onto the os coxae, right and left os coxae. So very big and weight bearing. This is a lateral view of the os coxa. It is 3 bones that have fused together. You can see here, this is how you spell it singular without the E, os coxa. The 3 bones are ilium, they're on top, ischium, which is round because you're sitting on it, and the pubis bone that comes to like a 90-degree angle where the pubic symphysis goes. So the best way to visually recognize it is this side is round like an ass because it is what you're sitting on. And this comes to a little bit sharper angle at the pubic symphysis. All 3 of those bones meet in the socket of the hip joint called the acetabulum. So these red lines are approximate where those 3 bones fuse. Everybody got it? But once they fuse, it's called an os coxa. All right. This is actually not as complicated as it might look. This is a right os coxa, which means you're coming at this angle. Everybody look at me. That means this is anterior, this is posterior. Everybody got it? Then the names are very intuitive. Anterior superior iliac spine. Anterior inferior iliac spine. This is posterior this way. So this is posterior superior iliac spine. This is posterior inferior iliac spine. And the big Dumbo ear up here is the iliac crest. Very straightforward for the ilium. This big guy here is a minus because the sciatic nerve was there first and then the ilium formed around it. That's the greater sciatic notch. I'll go over here in a bit and make another little sketch of this. In a little bit. But this is more on the posterior side. Remember, this is a right os coxa lateral view, which means this side is posterior. So sciatic notch is on the posterior side. Everybody got it? All right, we got the ischial tuberosity. This will be where a lot of your hamstrings originates from. And over there is the pubic symphysis, where the right os coxa meets the left os coxa with fibrocartilage. That hole in the inferior portion of the os coxa is called the obturator foramen. And the socket of the ball and socket joint, where all 3 of those bones fuse, is called the acetabulum. On that posterior side, this is more of a posterior view of the right os coxa. You could see the acetabulum going out lateral this way. You have the superior posterior iliac spine and the the posterior inferior iliac spine, and it looks like kind of like a 3. Let me show you. So those two notches are above the 3. So posterior superior iliac spine, posterior inferior iliac spine, and then below that it looks like a very gentle number 3. Does everybody see my blue 3 here? Do you see that? This is the greater sciatic notch. This is the ischial spine. This is the lesser sciatic notch. Those 3 make up what looks like to be a 3. Greater sciatic notch, ischial spine, lesser sciatic notch. Everybody see those 3 arrows and how it meshes with what I drew over there on the whiteboard? This is how the ball and socket hip joint comes together. Again, it's very weight bearing. So let's go to the femur. The femur is the only one that has a head that's actually separated off from the diaphysis. But also, what I wanted you to see here is maybe right next to where it says lesser and greater trochanter, right posterior. The trochanters are posterior. Look at it. Anterior view, you can only see the profiles of them. And the posterior view, you can see the whole thing. They're on the posterior side of the bone. Ready, got it? And the head is obviously going medial, so there's your 2 planes. Head is medial, trochanters are posterior. All right, you have this very round head. That's this arrow. But on the head, there's a little divot. And the word for divot is fovea. On the lining of your retina, you have a fovea centralis. It's a little divot. This is a fovea capitis, capitis for head. So this arrow up on the top right is fovea capitis, the little divot on this very round head. But this head is different from other bones with heads because this one has a neck. There's a bony strut that's separating the shaft or diaphysis from the head. And that's called the neck. And here you can see the profile on the anterior side, not the whole thing, but just the profile of the greater trochanter and the lesser trochanter. They're actually named for the size, not their position. Posterior view, now you can see the full trochanter. So you can see the full greater trochanter, the full lesser trochanter, head and neck. If you follow the trochanters down inferiorly or even distally, that would be the same, they form a kind of a funnel. And they funnel into this ridge on the posterior side of the bone, posterior side of the diaphysis, we call the linea aspera. It's a line on the posterior shaft of the femur. Then at the distal end, on the anterior side, we have a place where the bone gets really smooth. Really smooth where the kneecap or patella rubs up against it. That's called the patellar surface. And if this is a right femur, posterior view, that means this is the lateral condyle. This is the medial condyle. In Lab Exam 1, don't be afraid to actually stand there and look silly just to get the answer right. The point's worth it. Okay? Just don't touch any bone or model that has pins. You can only touch the 5 here that don't have pins. Everybody got it? Yes?
Is it the lower one is the lateral condyle?
This is the lateral condyle. This is medial. See, look it. Just right now, just so that I don't screw you up and give you the wrong answer, I just went ahead and did it. Right femur, posterior. Yeah, this is the lateral. Do that in lab exam 1. If I'm going to do that in front of y'all, you could do it in front of a station and get the answer right. Here is anterior view of the knee joint with the patella. Let's take the patella off of there. You don't have to determine right or left patella. And you can see a couple things. Number 1, the medial and lateral condyles of the femur articulate with the medial and lateral condyles of the tibia. Can you see that? What you want to write here, well, how many bones do you think is in your leg? You guys are kind of gun shy to speak out now. How many bones in your leg? 2. From your hip to your knee is your thigh or femoral region. Your leg is from your knee to your ankle. That's your leg. And all you have to do, and this is actually nice that we're back here in the room, is you have to let's look at comparative anatomy of mammals that are on all 4s. We used to have a horse skeleton that was over there, and it showed it really well because it is even more accentuated. But check out this, I don't even know what it is. But notice on the back limb, the femur is actually really short. Can you see that? In a horse, the femur is so short, it doesn't even come out of the trunk. The horse's knee is right there where that posterior appendage comes out of the trunk. That's the knee. So for the horse, what comes out is actually the leg. Your dog and cat are very much, I think some dog and cat is up there too, will actually be mostly leg. Very little femur comes out of the trunk. That's different from our bodies, but that's, comparative anatomy. In fact, have you noticed the back limb of a horse? It almost looks like the knee bends backwards. Have you ever noticed that? Okay, look at my foot. That's because that's not the horse's knee. That's the horse's ankle. It's just got a really long foot. In fact, it's got really long middle toes. Forelimbs are really long middle fingers. And the hoof is your fingernails. That horse is running, flipping the bird at everybody. Does that make sense? And so that thing that looks like a knee that's bending backwards, that's actually the horse's ankle. You can't hardly see the knee on the horse because it's up into the trunk. So you actually are seeing the leg though. All right, so look on the bottom of page 8. If there's 2 bones in your leg, which one is the medial bone? Just look at the list of structures there. Which one? Tibia is medial. The malleolus, those are the bumps on the sides of your ankle. The medial bump is the medial malleolus. That's on the tibia. It is the medial bone. Just write that down. The tibia is the medial bone. But what you can see here in this picture is none of the weight from the femur hits the fibula. 100% of the weight from the femur goes to the tibia. Can you see that? So here is the medial and lateral condyles of the tibia. Let's see, right, anterior. So this is lateral. Lateral condyle, medial condyle of the tibia. Between them, there's actually a prominent bump. And the prominent bump in between is the intercondylar eminence. This is the last bone you have to tell right from left. And this helps here. This is the tibial tuberosity at the bottom. It is anterior. It's pointed right at the camera. Anterior view, it's anterior. And the medial malleolus is medial. There's your two planes. Tibial tuberosity is anterior. You follow it on down inferiorly and you hit the anterior crest. Oh, you know the anterior crest if you ever snuck into your house when it's pitch black and ran into the coffee table. Because you know what's on top of the anterior crest? Hypodermis that we learned last week. That's sitting on top of the anterior crest. You rub into that coffee table, you are hitting bone right under the skin. There's the medial malleolus, and it's medial. So if you hold your foot flat down on the floor, you feel that bony bone on the medial side of your ankle. That's the medial malleolus. That's this thing right here. Okay. The fibula, which you will, it just doesn't have enough information to determine right from left, so I never ask it. That's how it sits. It actually sits below the lateral condyle. And it just has the head and the lateral malleolus. The head is more abrupt looking like a cauliflower. The lateral malleolus has a very smooth teardrop shape. But if you hold your foot flat on the floor and feel both of those bumps, medial and lateral, go ahead and do it now. If you are anatomically normal, the medial malleolus should be higher, just like these two arrows are showing. The medial malleolus should be just slightly more proximal. There's the medial malleolus there. And this is the talus, one of the tarsal bones. So we're almost done. Lateral malleolus there. And so what we have on this screen here is what I sketched out. You might have to come over and take a picture of it later because it's pretty small. There are 7 tarsal bones. So now we are on the top of page 8, and we're just finishing this up. Remember, I'm going to always ask it as a right foot superior view. Just like what's on the screen, just like what's on the whiteboard. Okay? Again, there are only 7 tarsal bones, and also your foot is different. You might want to write this down. Carpal bones is wrist. Metacarpal bones is palm. Phalanges are in the digits. Unless you're a monkey, your foot is different. The tarsal bones are your ankle and proximal foot. Tarsal bones are ankle and proximal foot. Your metatarsal bones are only the arch of your foot. You can see it here. That's the metatarsal Roman numeral 1 right there. And then the proximal phalanges are actually still largely in your foot. Only the distal ends of the proximal phalanges go out in your toes. Okay? That's why it's different from your hand, unless you're a monkey. If you ever look at a chimpanzee's foot, it looks an awful lot like a hand. All right, so let's go back to the tarsal bones. There's 7 of them. The largest one is the calcaneus, that's the heel bone, and that's the one farthest to the left. But all the weight actually goes on this bone with an X, that's the talus. The talus articulates with the tibia. 100% of the weight of the femur goes to the tibia, 100% of the weight of the tibia goes to the talus. Do I need to repeat that? Then there's a little disc here going out more distally from the talus, and we got the navicular bone. It's like a curved disc. And then we got this kind of squarish cube-shaped bone called the cuboid. And then we got 3 cuneiforms, 1, 2, 3. And you can call them first, second, and third. I like to call it medial, intermediate, and lateral cuneiforms because it reminds me of its position. Because your hallux, or big toe, Roman numeral 1, should be medial. If your big toe is not medial, you got major problems, especially with buying shoes. Okay, so the medial cuneiform is going to the metatarsal Roman numeral 1. Medial cuneiform, metatarsal Roman numeral 1. You need to know that the big toe is called the hallux. If you turn to page 16, on the bottom right, there is one hallucis muscle there, and I'm going to give you another one when we get there. Moving the big toe. And the same thing as with the hand, you got to know proximal and distal phalanges for the hallux, proximal, middle, and distal phalanges, and then use Roman numerals. We did it. We did it all. Any questions? I'm going to sit here till 4 grading. Feel free to look at bones if you want.